You're listening to the podcast of the Andrea Mitchell Center for the Study of Democracy at the University of Pennsylvania. Our guest today is Chloe Bird, a senior sociologist at the RAND Corporation and professor at the Pardee Rand Graduate School. She specializes in gender disparities in health and healthcare. Chloe Bird, thanks for joining us on the podcast. So you specialize in health and healthcare disparities between men and women in the U.S. What does that currently look like, and what are their underlying drivers?
Well, first you want to start out and look at the differences in men's and women's health. The old adage is women get sicker and men die quicker. And part of that is that men get more life-threatening disorders and at an earlier age. So we think about cardiovascular disease in men in particular. Women get more autoimmune disorders. Part of that is an artifact of pregnancy, or it appears to be that women's circulatory systems have to be designed to be flexible enough to carry a higher blood volume when they're pregnant. That's kind of protective because you've got more flexibility, less damage, less likely to have high blood pressure, and less damage from it. Similarly, women make more antibodies in response, whether it's to a vaccine or natural exposure. That's very protective for being able to ramp down your immune system when you're pregnant, pass on immunity to a fetus, pass on an immunity breastfeeding later on. But it's a double-edged sword. They're more likely to have autoimmune problems, partially as a result of that. The differences in their in healthcare in part come up because women live longer with more comorbidities. And we built a lot of the research mainly on studying men, but also the gaps in our healthcare system. The number of people who go without insurance ends up affecting women where we don't have a coverage for a lot of younger women. They may get covered after they're pregnant. During a pregnancy is a bad time to intervene most effectively, either on many of the chronic diseases or even on something like a form of addiction or other kinds of problems. And the way Medicaid has traditionally been set up, they got dropped off relatively soon after the end of the pregnancy, after delivering a baby. So we have these gaps that that end up not covering women during periods that can exacerbate health problems. It also leaves them more likely to have health problems in a subsequent pregnancy.
And what are the kind of policy fixes that you would recommend to fix these problems?
Well, one of them that's being looked at now is the possibility of extending coverage for not just a trimester, not just an extra 3 months rather than 6 weeks after pregnancy, but for a full year, so that you could manage and treat disorders, it makes a lot of sense. We all need, if we want to have healthy babies, we need to have healthy mommies. That wouldn't cover everybody, and it doesn't overcome not having taken care of health care in all young people, in everyone before they hit childbearing age. But I mean, one of the least expensive things to do would be for there to be, Medicare for children, universal coverage for children, great prevention possible out of it. But there are other ways in which we can do a better job in covering men's and women's care, including paying attention to the extent to which women have health. They have higher out-of-pocket costs, especially in older age. You know that men and women have differences in income. Those differences expand as you get older. They certainly expand as you go into Social Security. Women live longer post-retirement than men. They're more likely to be widowed, so they have lower incomes, even if they're lucky enough to have insurance that covers pharmaceuticals and has low copays for medical visits. Because they have more comorbidities, more different illnesses, they have more prescriptions. So even if it's fair because they have the same copay, it ends up being a much larger out-of-pocket cost with a lower denominator, a lower income, and that can result in. We've shown even in middle-income individuals, you can have incentives that encourage people to make choices that are not the best for maximizing their health. The same as can happen in other
such as
income. Not filling a prescription for antibiotics that they need, not taking a medicine as often as it's needed, trying to stretch it out. Classic case is people using the emergency rescue inhalers instead of using some medication that's lowering their everyday risks with asthma.
You mentioned that we need Medicare for children. Is that what you said?
Yeah.
What about the Hillary Clinton child insurance program from the 90s? Is that not a form of Medicare for children?
Any kind of policy. I probably shouldn't stick with branded names and concepts, but it's the least expensive thing we can do is cover all the children. It is in everyone's interest that we cover across the population.
Are we not covering children currently? Because I thought that was what the function was of the particular children's health care.
A lot of children, there end up being gaps.
Yeah.
The other issue that happens is we have churn. And churn is a term, people moving on and off insurance, people having to move between different insurance policies. One of the consequences, and this isn't about the children per se, it's about the women, of there being a change in their insurance during pregnancy, is they have to get onto insurance and then they have to get a provider who will provide at that Medicaid payment rate, which may not be easy to do at all. And so one of the things we're looking at studying now is what is the impact on coverage during pregnancy of a policy that doesn't cover women ahead of time.
Is there anything that we can learn from variation in Medicaid expansion across the different U.S. states?
I think we actually ought to be studying that very, very systematically and aggressively. One of the issues is it never would have been ethical to say, let's set up an experiment and cover people differently all over the country. The poorest will have different levels of eligibility. Consequently, we could never show, based on current data, what is the value, what's the impact of having different coverage rates. What do we do in terms of saving dollars? What do we do in terms of saving lives, reducing different kinds of complications or ER use? And now, because we have these different rates of uptake in the Medicaid expansion, we have an opportunity, and I would say almost an obligation, to go and look and see what does it result in. How can we show what is the cost of not covering individuals, and what gets saved when you do cover individuals?
So nobody's looked into that at this point?
There are people looking at it somewhat, but it hasn't been a funding priority. So it's not easy to jump in and start doing it. I'm also interested in how, to what extent are differences in outcomes across racial ethnic groups a function of the geographic distribution of groups. So to what extent is the higher morbidity and mortality in pregnancy of African American women compared to white women differential exposure to these policies? We're not randomly distributed. And so, there are a lot of questions that we could ask.
You are also interested, maybe more interested in the question of scientific research on health and the fact that we don't have as much evidence about women's health as we do about men's health. Could you say something about that?
It's fairly striking, and most of the time we don't even realize it. I mean, we're not that many decades into trying to develop evidence-based medicine, but for a long time that was done primarily studying men. Actually, even the mice and rats were primarily white and male. It's sad. It's sad that it's still a relevant joke.
They were
white
mice,
white mice and white rats in the research. It was understood that you got different results when you studied females than males, but the belief, the hubris at the time was, well, that has to do with known hormone variations, and that we know what that is. It's just introducing noise. It would just take more data to understand what's going on in women, but we know all of it. We didn't actually know all of it. It was an assumption. They were untested assumptions. That combined with DES and thalidomide, both of which led to a lot of toxicity in pregnancies and birth defects, pushed, at the same time we were developing policies for research, human subjects review, to say we should make sure that never happens again. We should make sure that we are never exposing women who are pregnant to drugs that could harm their fetuses. As a result, women who are pregnant, there's a tremendous amount of medications we don't know whether they can have. We expose them, but more so because we don't have information on what to do and what not to do.
So how can you do experiments like that without putting women at risk and their children at risk?
Well, part of it would be to collect a lot more data on what utilization does happen, because there are times when you have to do something for women who are pregnant and so on. The bigger issue is that in the up until about 2000, there were restrictions in place on women consenting and participating in a lot of medical research. Women were put in the same category with children and those who were mentally deficient or compromised, unable to consent. They weren't allowed to participate in studies, and you couldn't say, "Hi, I'm a lesbian. There's no chance of me getting pregnant. Hi, I'm someone who is not in a relationship. There's no chance of me getting pregnant." That wasn't the approach. So you're probably familiar with there being some studies that were done in nuns. Nuns were trustworthy.
I'm not. Tell me more.
Well, there were a number of different studies looking at the longevity and well-being and health outcomes in nuns, because then it was reliable that they weren't going to get pregnant.
When are we talking about?
We're actually still following in the nun study. There was a piece that I saw reported on the other day looking at Alzheimer's rates, and that was population observation work, looking at how the number of languages you learn is associated. More languages, lower risk of developing Alzheimer's, at least in women. But if you think about it, here we have this practice because it was thought that it was good enough. It was thought that it was reasonable to generalize from men to women in medical research and in treatment. We didn't do the work on women. Then we entered a period when we needed to add in women. It was part of the requirements of the NIH Revitalization Act that women be studied, and so they started adding some women to the studies. So we kind of got to the add women and stir, comparable to history. We're not going to change and rewrite and teach history and where women were. We're going to add Women's History Month.
So what do we really have to do?
Well, what we really have to do is to start to analyze the data and question: do we get the same results for women as we do for men? And in some of the fields, particularly in some of the animal research fields, they found not only do they not get the same results, but it is so different from what they assumed they knew that it is that a number of researchers shift completely to studying female birds, female studies of the rats and mice. But we need to include women in the research, and the premise that we could generalize from them is not valid. At least that we don't even need to look. We now know that biological differences go down to the cellular level. There are a variety of ways in which there are differences, as well as the differences I already mentioned in the kinds of diseases and age of onset in women as well as men. And we know that there are all of these differences in the life course, in the nature and amount of exposures men and women have. So if you don't have evidence that the two populations you're looking at are otherwise similar, mathematically that the correlation matrix is the same, then just throwing in a binary variable to adjust for that isn't defensible. And it doesn't really get us to the results we want. I mean, the assumption is we can get to one size fits all. One size doesn't fit all in underwear. I don't think it's enough in healthcare. But one more piece that goes with that is if we do put in the binary variable, if we do come up with what the answer is, it's as if we've come up with results that apply to this average person with one testicle and one ovary. mathematically, that may be an average. It's certainly not the mode. It's certainly not, I don't know that I've ever met them. It doesn't mean they don't exist, but that's not who we should be making the medicine for. At least not first. And it would require a lot of changes to do better.
So is this something that would change at the level of private research institutions, or is it something that the NIH would be responsible for helping to push forward, or where do you start on this question?
There's several ways we can start. One, I would like to see more disparities researchers get involved in doing evaluation research and doing medical research and helping ask better questions. If we ask better questions, we will do better science. We can engage journal editors for healthcare and medical journals in raising the standard and saying this actually is indefensible, this isn't good enough. We can engage in NIH in looking at this more seriously. I mean, you've got to understand that our understanding of racial ethnic differences in response to specific treatments doesn't come from having done studies that included enough to look at it usually. It comes from reporting the findings of and looking and following the signal and the noise, if you will, looking for evidence that there's a big enough difference that we need to go do a study. So we need to provide better value, better systematic evaluation when we report out on studies, so that and the next researcher can come along and say, wait, we keep finding this. This is something we need to go and look further.
So just one specific women's health issue that I wanted to zoom in on, because you've written about it, is over-the-counter emergency contraception. Could you say what your research on that has been?
Well, this is interesting. We're looking at the policies that expanded access, starting to provide over-the-counter sales, since it happened at different time points in different
And this
states.
is for the, just to clarify, this is for the morning after pill?
Yeah, emergency
Yes.
contraception. The most widely known brand is called Plan B.
Plan B, right.
Plan B. When we originally proposed this, I was thinking there's so many hurdles to getting access to that, to dealing with having had unprotected sex for whatever reason that happened. It's accessible if you can afford to previously to go and have an appointment with a provider, go and get a prescription. Not everywhere even carried it, and then take the medication, and it was enough to catch up, so that an egg wouldn't implant, fertilized egg wouldn't implant. So it's not causing an abortion; it's preventing a pregnancy from happening after the fact. It turns out that yes, we're very preliminary in this. There's evidence that there's trends across racial ethnic groups and access, but it may be the case that just the fact that it's still $50 is, for many, there are women for whom it's worth $50 to have the insurance that this didn't happen, and there are women for whom $50 is a huge part of their income for feeding themselves and their children, for keeping a roof over their head. So it may, as we understand what the results are, it will help us inform what would you do in order to make it accessible, in order to reduce costs. Because we know that every dollar put into contraception greatly reduces, 5 to 7-fold, reduces public dollars that get spent after the fact.
Are the pills the same price in, say, Canada? Because we hear a lot about drug price differentials.
Well, they wouldn't be the same price in part in Canada because many people have pharmaceutical coverage, so they have lower copays. Not an expert on this specific medication and it being lower, but I believe that it is.
So that points to
lower.
the question of universal healthcare, just getting everybody covered.
A big issue is getting everybody covered. And another big issue is looking at to what extent has the healthcare system evolved, built around a model that was treating men, and women's reproductive health is this separate module of obstetrics. It's treated as if it's kind of this plug and play module that, you've engaged the pregnancy subroutine, and as soon as it's done, you'll just go back to the regular population. But in fact, many chronic diseases either have some onset during pregnancy or are complicated during pregnancy. And it is a time which it is very difficult to intervene thoroughly and effectively because you've got to balance protecting a fetus. So it's not a perfect time to provide health care. It's one of the many things that extending coverage, at least beyond pregnancy, but ideally before pregnancy, could help protect. But it's important to understand that it's not just an artifact of the differences in men's and women's biology. We could have had a healthcare system that was built not on internal medicine, but on kind of family practice where reproductive health was more integrated into the healthcare delivery. It's possible to imagine a system where some aspects of men's health might be a little bit more of outliers.
Dr. Bird, thank you for being on the show.
It's a pleasure, and thanks for having me.